So first, we are here at the World Oncology Forum. I was at the first one, which was a little over 10 years ago, a decade ago, and the message is a very different one. So one thing that I think has changed, and that's tremendously important, is that today I believe the global health world understands that cancer is a health, equity, and economic imperative for low and middle income countries as well as for high income countries. A decade ago, that was a message that we had to push and push and push because we were told over and over again that was not appropriate because low and middle income countries had to focus on so-called diseases of the poor that were a certain small set of communicable diseases, particularly TB, malaria, and HIV. In today's global health world, we understand that non-communicable diseases are a priority, and within NCDs, the cancer is of the highest priority. We also understand now a message which is unfortunately something we are all quite comfortable with, which is that the poor suffer and die from both communicable and non-communicable diseases more than those who are not poor, both countries and the poor within countries. I say that we're comfortable with it, meaning that we know we have to do something about it. A different question is, do we actually know what to do and how to do something about that? And post-COVID, which is something we haven't talked about very much here, interestingly enough, I think that is a major question. We have made progress, but we've made progress in the face of COVID as well. And this is also why I'm being hesitant about what I'm saying in terms of how far have we come. I do believe that we're going to see a tsunami of cancer, late detected cancer, treatable cancers. And even though our baseline for low and middle income countries was frankly not anywhere near I'd like to say it was, COVID pushed that all back in a very particular way for cancer because we already had late detection. But now we have several years in many countries of much later detection. And what that is going to mean for countries in terms of cancer has me considerably concerned. What are we doing in terms of some of the other points? Policy. Are countries discussing this? Are countries thinking about strategies? And I do think that we have some very important and specific country examples and also some incredibly important and interesting platforms for financing particularly cancer medicines, but also other areas of treatment and early detection that are novel and new. And yesterday I talked about that in terms of an economics of hope. We talked about a recently published paper and an incredible initiative in India that was led by Tata, where what they have managed to do is bringing together about 250 centers for 40 specific medicines, dropping the price by about 85% in terms of the reserve price and what these centers were facing, particularly the smaller centers before that, and an incredible sort of future vision of being able to include other countries from the region in this sort of a platform for doing purchasing and financing. And that is something that the world learned from what was previously done in global health. So we saw the Global Fund, we saw Gavi, but were they really doing cancer? Maybe a little bit on vaccines, but not much. I think we're seeing these new initiatives national, and I'll comment on another one that I think is very global in just a second. So we're seeing these new initiatives that learn from what's going on in global health, and they can go a tremendous way in terms of allowing us to be able to finance access to medicines and treatment, essential medicines, essential treatment in low and middle income countries. So one was India and Tata. And the other is, also spoken about yesterday, is what St. Jude's is doing, St. Jude's Cancer Pediatric Children's Hospital is doing now with WHO, the World Health Organization, and with UNICEF, among others. But this has really come from this private hospital based in Memphis, St. Jude's, that put aside $200 million into WHO for a fund to be able to finance pediatric oncology medicines, essential pediatric oncology medicines in low and middle income countries around the world. Why is that so incredible? I mean, just for what it is, that this will allow countries to be able to work together to get a much better price. That's one. But it also includes a health system strengthening component and options to be able to help countries bring their health systems around cancer up in a way that I do think speaks to an economics of hope. But the other piece that really strikes me, and yes, this is change from the last WOF, is that, in our world of global health, we would not normally have thought about a private hospital in a relatively small city in the United States financing a major global initiative. And that should give us a huge amount of hope, because what it means that in a world where we're often saying the resources aren't there, the initiatives aren't there, that they can come from different places. And that we can think about these kinds of global and national collaborations that can truly lead us to the kinds of answers that we need in order to be able to stop cancer now and in the future. We are speaking in this case about children. It's a specific question. Sometimes we're thinking about vaccines, another specific question, but those are the places where we can see more than low-hanging fruit, because I don't think it was ever all that low-hanging. We can see dramatic institutional change and collaboration, private, public, and international, that can change the face of cancer. And that gives me a lot of hope. I do want to bring it back to some of the global political situations. I wasn't speaking initially to the Mexico case, but I will do. Leading an NGO in Mexico and working and understanding the Mexico case. A few years ago, I would have been putting forward Mexico and the Seguro Popular as an incredibly important set of lessons for the world. And I do think that's still true for those who are not aware of this case. Mexico had a major health reform, offering pooled public financing for all of those who were not insured through Social Security, about 54 million people, and that grew, and it very innovatively included a catastrophic fund for certain cancers, and that fund also grew. And I was part of setting that up initially in President Fox's administration, and then it grew. But unfortunately, it was closed. And this is where the overall lesson is a very important one, I think, which is that politics can destroy some of the most important institutional advances and lessons. The good news that's still there is there's a lot to be learned from an initiative like the Seguro Popular. But when I think about it in the country I call home, I worry tremendously, particularly in the face of the pandemic, that these incredibly important spaces for being able to give cancer patients access to essential treatments were simply erased at a very, very difficult time. So the lesson there is, I think, how do we safeguard what we have achieved for global cancer from political upheaval and change? And without judging, is one politician better than the other, I talk about upheaval here, which is these institutions should be able to withstand the very strong winds of changes in who is the leader, because we have evidence, we have proof of what works and what doesn't. We need to adapt and change policies and programs as we get more science, more evidence, that's clear. But what we do not, I think, do is destroy institutions that have been so difficult to develop. I spoke about the Mexico case because I know the Mexico case. But we can think about countries really all over the world, particularly the poor countries, some of the poorest countries, that suffer this continual upheaval from politics, that suffer this upheaval from other kinds of natural disasters as well. And how do we guard our programs from that? I think that's been a tremendously painful lesson for many of us. Another area, you mentioned palliative care, you mentioned palliation. I think that we have a much more novel approach to this now than we did when I led the Lancet's Commission on Global Access to Palliative Care and Pain Control. The more novel is that we are now linking supportive care or survivorship care to palliative care, and I think that's the right way to go, because we never know when any of us are going to go. I say that also as a patient, and we want to think about a whole survivorship journey. That said, which is, I think, a huge move forward in how we can think about patients' access to the alleviation of suffering. We still see, and here I think we've fallen off tremendously, a global pain pandemic. We talk about, in the work I'm doing, an opioid crisis, or an opioid epidemic that affects a certain number of countries, primarily the US and Canada, and a pain pandemic that affects the entire world, and particularly the poor and poor countries. And there I include in poor, because it's a poverty of access to pain medication, upper middle income countries, lower middle income countries, and low income countries. The 50% poorest in our world have access to 1% of the opioid medications, and I have looked at those data, and though we see over, say, a 30-year period, some small increases in access, they are very small compared to need. And we are nowhere near dealing with this issue the way we have to. And what has happened, unfortunately, I believe, is that the opioid epidemic or crisis, which is a crisis and about which so much needs to be done, has left even more opaque or shadowed the need to be able to do something about the pain and suffering of the poor. And we don't even know how to measure that properly today. And we know we have to measure it. We are not measuring it, and we are doing very, very little about it. And I do see a lot of backsliding on that point. And the saddest thing there, I think, is that this is not one of the problems in global health that's too costly to be able to solve. It's incredibly inexpensive because the sorts of medicines we really need are morphine, which is off patent. We talk about $145 million a year to close the global pain divide in palliative care with morphine equivalent. That is a tiny amount of money. It's about what a mid-sized hospital in the US gets every year, but we don't have that. So it's not money that's blocking it. The problem is politics and policies in the face of the opioid epidemic. And so we are not doing the right work on either the epidemic or the pandemic. And so we have people suffering on both ends of the spectrum in ways that we know how to stop. What I usually try to say, I haven't been able to publish it yet, although I've wanted to, is that the way we treat this is as though we were telling people who are undernourished and do not have enough to eat and suffer from severe malnutrition, that the way to avoid obesity is continue to be starving. It makes no sense, and that is how we've dealt with pain in our world. You know, the standard answer I think that we would get in global health is that we know that there's a tremendous amount of prevention that we can do with good public health policies, with some vaccination, with screening of some diseases, and then with access to the basics of treatment. We know we could save many, many lives in ways that are not tremendously expensive in the face of cancer. We know that. Is that the only thing we can do? I'm not so sure. I think we can think bigger, and that's what we're talking about in our new Lancet Commission on Cancer and Health Systems. I think we can think about closing divides, but also raising the bar. So I think we're in a world, and here we have to speak much more positively than I did on pain, a world post-COVID where we have the opportunity to harness technologies in ways that we have never seen before. It would have taken us decades to convince countries or insurance companies or insurance programs and social security programs to be able to cover telemedicine. We were nowhere near there before the pandemic. Today, that is virtually a given. Now, what does that mean for cancer in our world? It means that we can bridge distances to the poor in ways that we could never have done in the past. It was inconceivable. And that is for detection, that is for understanding need, that is for survivorship, and that is even for palliative care. And so I'm incredibly hopeful that if we think in this economics of hope framework, that we can achieve a kind of access that defies geographic boundaries, that we can do so much more than we thought about doing before, and that instead of thinking about these sort of small essential packages, what we need to think about is new ways of achieving global access. We're never going to have it all, but I think that we can think way out of the box and be able to do so much more in the world that we're in.